Yeah.
I'm obviously got a very different
Sure.
mindset than most people in the room, in that I just come from a completely different system, so I'm coming at it from a very different perspective. But please don't use the word socialized medicine. It's just like such a misnomer. And we're extraordinarily capitalist country, but yes, we have this like sense of everyone should be able to have some healthcare, which is quite nice. And like I work in a free clinic here in a church basement, and it's just like, is this a third world country, or is this like one of the, this country likes to think of itself as the richest nation on earth. In so many ways, it's so behind, and some of medical innovations are fantastic, but so where is the money? If America's spending 17.5% of its GDP on healthcare, where is it going? To researchers? To pharmaceutical companies? I don't know, but it's not going on a lot of the people, and it's not reinforcing the system in a productive way that I can see at the moment.
Well, I will notice in the Lancet article, UK finished dead last.
I'm not. Oh no, we know our cancer rates are terrible, and we're working on them.
And I also point out that under the Blair government,
I'm not saying that. I'm not saying our. I'm not saying. Okay, I'm not here to say our system is great.
Okay.
Is perfect.
I have some other criticisms.
Yeah. I have many criticisms of my system as well, but I like defending it because I think a lot of the criticisms from here are from such a different mindset, and people just can't. Like you just said, it's like that, it's we are here for ourselves, and I want the best for me now, and I'm not going to look to the future, and I'm not going to think about my fellow citizens or my children and their future. I want what's best for me now, and we need an answer now. Whereas in the NHS, we're 60 years into it, and it's still an experiment, and it's still very much a work in progress, and we're sort of like, okay, it's really getting there. We're like so much better than we were 60 years ago, but we've still got somewhere to go. My one actual point to make was your point about, so an older person is going to pay less while younger people are going to pay more. But once you get to being that old person, you'll also pay less. So, that will balance.
But you'll be wealthier at that point. Part of it, my problem is yes, to some extent with social insurance, the idea is you pay when you're young, and when you're old, everybody who's young will eventually be old and they'll redistribute. But the problem with that is older people are generally wealthier than younger people. So the redistribution takes place at the wrong times. I mean, in a sense, if you had older people who redistributed to younger people, and you could say that's fair because everybody, would eventually be redistributed to, and then later on they'd redistribute back. But you're making redistribute up the income scale. You're essentially making poor people pay for rich people.
Well, no, but except then you hear the stories of the older people who get kicked out of their homes because they couldn't find insurance. They covered their
older people are covered by Medicare in this country. They're not being kicked out of their homes.
Do they get the choice on Medicare that they would get under?
Medicare actually you get one of the most choices of all, which is why it's $70 trillion in debt, because basically Medicare is a check writing machine for seniors. But let me go back again to sort of the fundamental issue of this. We are not no society, UK, US, is going to provide unlimited health care to people. And I'll give you just a classic example. If every time everyone got a physical, when you went in for your annual physical, you got a CT brain scan, we would catch maybe a dozen brain cancers in this country early enough to save people's lives that otherwise would die from that brain cancer. On the other hand, we'd bankrupt the country overnight because it's $1,000, $2,000 a pop, give them that CT scan. We're not going to do it. Now, there's two ways to look at that. Some countries, UK would be among them, would say that's just inefficient. We're not going to let you have a brain scan. The US says you can have a brain scan if you pay for it yourself.
We say that too.
Well, about 13% of people have private. I mean, you also have the situation that if you pay for any of it out of pocket, you can't accept any NHS.
No. Not across the board. Like for some, and that's changing all the time.
I understand. It's evolving in a more market-oriented direction, which is what most of Europe is doing, adding more co-payments, more consumer cost sharing, more out-of-pocket, more private insurance. I mean, basically, there's more market-oriented activity taking place throughout most of Europe in response to this. But ultimately, what I'm saying is that decision on rationing is either going to be made at the government level or made by the individual level. My question is, I think it's better to have the individual making it. You can always throw in subsidies and help them pay for it, but they get to make the price value decision about how they want to use their money versus having a third party make those decisions. Just following up on my thing about Europe, if you look at those countries that have actually fairly functioning universal healthcare systems, I always sort of divide it. You have the centralized command and control type of healthcare systems in Europe, and any of those that actually work. The ones that actually work pretty well are the Netherlands, Switzerland, and France. Probably are the three best. They are the three most market-oriented healthcare systems. High degrees of consumer cost sharing, co-payments, deductibles. Doctors in France can balance bill over and above the reimbursement rate, which is why you don't have rationing by queue, you have rationing by price. Essentially, the best doctors charge more, and people have to pay if they want to get in to see the specialist and so on. So that avoids the sort of rationing by queue, the waiting list that occurs in some other countries. So you're having more and more of these market-oriented reforms introduced in Europe. At the same time, we're trying to move in the other direction, which I think doesn't work. So something over here, yeah.
Yeah. I'm curious as to how you came up with the number of future enrollees in the public option. It really sounded like a number that was pretty similar to the Lewin Group, which is owned
by United Health. Yeah.
By a health insurance company, and the CBO actually said
6 million.
6 million. So
yeah, let me give you the way the two are different. First of all, Lewin Associates is owned by United Health. Lewin Associates also has been repeatedly hired by people on the left to price out universal healthcare systems. They just most recently did it in Colorado for the Colorado Healthcare Commission and stuff like that. It has traditionally been hired. It's only gotten to sort of now it's owned by a health insurance company because they came out on the wrong side of this, but traditionally they've actually been a group that I've had criticism of the methodology for because they've been traditionally hired by the left. But the reason for the difference between the CBO study and this, the CBO again is sort of limited by the four corners of the way the language of the law works. And the primary difference is the law says that the public option initially will only be open to people who are currently uninsured and to businesses that have 25 or fewer employees. And for the first 2 years that's all it'll be limited to. It then says, but after that, the Secretary of HHS would have the power to open it up to any other groups. CBO can't look at that. Can't assume that the Secretary will open it up. They say, it says 25 or fewer, that's all we can estimate. If you assume that's always going to never be more than 25 fewer employees than the currently uninsured, then 6 million people will ultimately be shifted in it. I just don't buy that. I think the press is going to... I'm assuming it's going to be opened up to everybody.
Is that a fair assumption?
Yeah, I think given the politics, and I do couch by saying as many as, but I think it's a fair assumption to assume that the politics of it, is going to be pressure to open it up to everybody. That's, the left is pushing for that. Has always wanted
to acknowledge that it's a political forecast instead of a cold economic number.
Sure. Because the cold economic man is 6 million.
So there's only a chance that the number
if you believe they can hold the line on it, if you believe that a couple of years from now, when insurance premiums are rising generally, if all these things haven't kicked in, if people are still paying more, health insurance costs are rising out there, and the health and the private and the having a cheaper public option, and people are saying, businesses, why can't Ford Motor Company saying, why can't we put our workers into the public option and save money, because make us more competitive? Well, why not? That the Secretary of HHS in the Obama administration in the second part of its term is going to say, no, we don't think so. Then you're right. It'll only be 6 million. I just don't see. I look at the pressure. Every government program ever started is expanded in scope. I don't know of any program where the government says, "Oh, we're going to cut back on the program we just put in place," or "We're never going to expand this." I just don't think politics works that way. The nature of things for government to expand and liberty to contract, as Thomas Jefferson said.